Hello, everyone. Thank you for joining us today for Athena Health's Marketplace Partner webinar series. We're excited to have you with us today. We're thrilled to be joined by our featured partner, Wellbe, who will be sharing insights that support your success on the Athena Health platform. Before we dive in, just a quick housekeeping note. We encourage you to ask questions throughout the session. To submit a question, simply click the Q&A tab at the top of your screen. We'll address as many questions as we can during the Q&A portion at the end of today's presentation. And now I'm pleased to welcome Seth from Wellbe. Welcome, Seth.
Thanks, Nikki. Good afternoon, everyone. As Nikki said, my name is Seth Merritt. I am the founder and CEO of a company called Wellbe Health. And we're just going to talk a little bit about some of the benefits from AI and also how you might be able to use that for an outsourced care coordination model. And just hoping that you were able to learn some information about what's out there from a technology perspective, and then solutions like Wellbe and how it might be able to help your practice drive additional revenue and streamline some of your workflows. So I will start with a blunt statement that we all know that the current primary care model is essentially broken. We know that panels are growing, chronic complexity is increasing with your patients, and your clinicians are being asked to do more administrative work than clinical work. That ends up killing morale, killing access, and reducing patient outcomes. Today, I hope to show you a practical path out of that cul-de-sac, one that's actually using modern AI to automate the routine, and a nurse-led outsourced care model that helps you scale clinical judgment and improve both provider and patient satisfaction. So the goal here is not to sell smoke and mirrors. It's really to give you a pragmatic playbook that is designed to reduce clinician burnout, increase access for your patients, improving clinical quality, all while capturing real reimbursements that makes this a financially sustainable model. Wellbe built its model to work inside the workflows that you already run on, specifically for Athena customers. That really matters, and Athena's a great partner for us because we know that Athena has to stay the single source of truth for you and your workflow. So over the next 40 to 45 minutes, I'll just walk through the problem, some of the policy tailwinds, a build versus buy scenario, and then some hard outcomes that you can expect with these types of solutions. I'll go through a quick look at an AI that we named Marcus in an Athena connected environment in our solution. And then when we're all done, I'll put together a simple pilot you can act on as an option to see if this works in your practice, or also give you a framework for how you could build something like this internally. If you want to skip the preamble and see what this looks like, we will get the demo about halfway through. And then for the rest of you, stick here. We'll keep it pretty practical, candid, and anchored on what's driving results, which is what you all want to see. And that's why you're spending the next hour with us talking about this and hopefully coming out with some real benefit for your practice. So why are you listening to me? Why do you care? Just a quick rundown on me. I've spent the last 15 years building and operating new care models with both health systems and primary organizations, both from a startup technology perspective like Wellbe, but also with a lot of the large payers like Anthem and Aetna building value-based care models and ACO products. So I understand a lot of the challenges you all are facing and also what the payers are looking for in terms of how you're actually driving outcomes and how you're getting preferential treatment from the payer. So I started Wellbe about 5 years ago because the problem I see is obvious and solvable. There's just really too many amazing clinicians that are getting trapped under administrative work, and a lot of your patients who need support are falling through the cracks between those office visits. The vision at Wellbe is simple. We want to increase provider capacity, improve patient access, improve patient outcomes, and make actual care management a sustainable and revenue-producing function for our practices. How to achieve that goal is really difficult and something that our team is working on every day. But with some of the technological advances like AI and in evolving reimbursement models, it's increasingly making more and more sense for providers to really leverage technology as a core part of their patient engagement and care strategy. Wellbe specifically does that by combining our AI platform that we call Marcus with a nurse-led care team, so that we're using technology to amplify human judgment rather than replacing it. So a lot of buzz around AI is talking about like replacements of clinical services. We think it's really designed to kind of supercharge the clinicians that are already doing the work and taking away all the routine and allowing providers to focus on what they do best, which is actually interacting with patients. For Athena customers with Wellbe, the technical promise is pretty straightforward. We have a very tight bi-directional integration, leaving Athena as the authoritative chart and billing hub, while solutions like Wellbe automate the monitoring, the documentation, all the routine interactions. From a clinical view, our promise is that RNs getting supported by our AI handle the day-to-day, so your physicians spend more time on what actually requires their expertise. And that combination, the technology plus experienced clinical teams, is how you can scale compassionate, safe care management without burning out your staff, both from a clinical and administrative perspective. So, let's be honest about the problem we're trying to solve. It's pretty large, and I'll walk through how we think about it from Wellbe and how you might think about it from a practice perspective. So this slide is really, the uncomfortable truth that the work required to actually deliver whole person care that everybody talks about has outstripped the capacity of most primary care practices. Most practices do not have the capabilities to deliver that whole person care, and they're struggling to keep up, both with their physician clinicians, their administrative staff, their support clinical staff. It's just a lot of work, and keeping up with the ever evolving expectations is very difficult. If we're being honest about the work being asked of primary care physicians, 90% plus of US spend is driven by chronic disease, which is not an acute problem that gets handled by an office visit or a surgical intervention. It's a different model of care than what was delivered 15, 20, 30 years ago. Your panels are growing. Behavioral health and social needs really sit squarely inside the job description of primary care, and you have to have solutions that solve for that. At the same time, your EHR documentation and clicking are just siphoning a lot of clinical time. Half of primary care physicians report burnout, looking to leave the practice, which is not just a statistic in our mind, but an operational crisis of care. This results in worse access, reduced continuity for patients, and care that's just reactive instead of proactive, and is never going to deliver that whole person care that people want. And while whole person care is the right clinical goal, it ends up being more work per patient. So you're asking more from your providers to deliver it. And without redesign, practices are either going to reduce access or sacrifice thoroughness to add this new level of service. And really, that's how we see automation and an outsourced care team coming into play to help your practice deliver this level of care. And most of the practices that we work with that are talking about this are trying to move into that model of much more whole person care, and they can't do it with the typical in-person office visits. What we are trying to do with our model is offload the routine work, provide continuous support for your patients in between those office visits, and then making the actual in-person time that much more effective by having your providers arrive prepared with clean, contextualized data, high quality nursing outreach for your patients, and making sure that both the patients and the providers are ready for care when they come in for their visits. And that's how solutions like some of the AI tools and these outsourced care programs are able to deliver better outcomes for your patients and a reduced burden on your physicians. So knowing that the scope of the problem is pretty large, I'll explain how Wellbe specifically leverages AI and automation along with our care team to deliver those types of results to patients. So AI is not magic. It's not like you can just deploy AI and everything gets fixed. It's a practical toolkit that can remove a lot of routine work, and also it can be there to amplify clinical judgment. It's just a matter of how you deploy it within your practice and how you're utilizing it and where you want to start, whether it's through intake and patient engagement, whether it's clinical decision making, whether it's note taking. There's a lot of different tools for AI and how you want to leverage that. If you remember two things from this slide, I would say there is Marcus, which is Wellbe's AI clinical assistant, is able to automate repeatable, and the nurses can provide the human judgment required. So I will walk through what AI is doing in operational terms, and think of these from your perspective in terms of who is doing this work today in your practice and how much of a burden is it on your staff in terms of the hours they commit, every day, every week, every month of practice, because a lot of this is repetitive stuff that really can be pushed to AI. So think about risk triage of patients. How we're thinking of it is continuously scoring and prioritizing patients so your teams can see the cases that matter. If you're trying to look through data every day, every week of who are the rising risk, high risk patients that are going to qualify for some sort of pay for performance program, that's a lot of work. You can automate that with AI, and this pre-filtering is, why in deployed systems only 1% of our alerts really require physician attention. The AI is there to separate signal from noise. AI can analyze remote monitoring data. So the data streams from blood pressure monitoring, weight monitoring, glucose monitoring, those all become streams and trends, and the clinically meaningful flags, rising BP over days, weight trends for heart failure or arrhythmia patterns. AI can translate that into context, so you don't have to be monitoring those in real time, but also being able to get information those patients that are rising risk that actually do need engagement. Patient outreach to increase compliance and engagement, how to automate SMS messaging, voice nudges, sequenced check-in, improving patient adherence for devices or medication management, and all the follow-through. So AI can choose timing and channel for the highest lift for patients, whether that's getting them engaged in any care programs or even just reminding them in for visits. Those are things that AI can do. Note documentation. So for us, a big thing in terms of doing this care management work is documentation to make sure that it's covered for reimbursement purposes. AI is able to draft really structured billing grade notes from device feed, phone call summaries, outreach events. That's eliminating hours of after visit paperwork and creating consistent documentation for audits. So those are a lot of the workload tools that AI is already doing and just only going to expand in terms of delivering some of that day-to-day operational work that probably a lot of your staff is working on doing internally if you're trying to manage these patients between office visits. This also handles nurse reminders and task creation. So if you're identifying a care gap with a patient, systems can auto-generate actionable tasks. So patient missed a reading, patient has an appointment upcoming, what needs to be outreach to them. That can actually include context for the nurses and route to the appropriate person. So whether that's an NP or an RN, an MA, or non-clinical staff, this can automate that work to make sure that you're getting it to the right team member for the lowest possible cost. All the phone transcription, documentation, calls gets transcribed, clinical points get extracted, and you can draft a note from that call for an RN to review. So there's no backlog in transcription. The clinical artifacts are actually created at the time of interaction, so you're not running after the fact trying to redocument your phone calls and your interactions with the patients. And for us, we create a lot of care plans for these patients. So our AI is pulling together individualized care plans based on the patient diagnosis, risk, social needs, prior engagements, and then those plans become starting points that nurses can then customize for the final plan. So again, that's a lot of operational capabilities that get completely sucked out of the system through AI. And this is going to only increase as the technology gets better and more integrations in with the EMRs. We also use AI for clinical engagement and support. So how we empower our nurses to use the data in a more efficient way. So we use this for clinical assessment where our nurses are, interpreting these signals in context. So, comorbidities, home environment, recent events, things that only a physical person is going to know. Our nurses are able to apply judgment on that clinical intervention, provided by the AI and not just accepting a score. So there will always be the need for physical human presence on this. This is just making them act more efficiently. We are also using our clinical team for model training and feedback. Our RNs are actually validating all the AI recommendations and putting corrections back into the system. This feedback loop really prevents drift, which is a concern for anything you're doing with AI and clinical decision support. If you're not having a human in the loop at all times, this can actually lead to really bad hallucinations and non-appropriate clinical interventions. So this feedback really increases the accuracy over time, and that's something that you really need to think about as you're deploying AI. Also, from a human perspective, patient support and engagement is critical. Trust is a human thing. Our nurses build relationships, coach that behavioral change, and work to keep patients engaged from a human perspective. And that engagement is how this basic monitoring turns into outcomes. And also patient prioritization. Nurses ultimately make the final escalation decisions, balancing this AI algorithmic priority with real world nuance around social risk, availability, patient preference. That is all super important. And then clinicians and nurses define the concrete pathways. So like what counts as an escalation, what needs coaching, what needs a referral. Well, AI can automate a lot of the repeatable steps in the pathways, ensuring this consistent care at scale is very important. So um, just reality check on the impact. When the loop is implemented correctly with AI pre-filters, nurses close the loop, documentation is automated, practices can see a measurable lift. And it's just all important about how you're thinking about using these tools to stand up and maintain an outsourced care management program. And also just something to think about as you're considering how to deploy this internally and what tools you would need to actually like build this in-house. For us, we've seen this model freeing up 20 to 30% of time for each nurse, saving about an hour of time for each enrolled patient per month when done correctly, which is delivering a lot of value for the practices we work with. Bottom line, AI can handle triage, data synthesis, patient outreach, documentation, tasking, call transcription, care plan templates, a lot of work. And nurses can provide that clinical assessment, model feedback, engagement, prioritization, pathway design. And really, that's how we think of using this combination of human intervention and AI to give you scale without losing that safety. And really, why this matters is next, the routine activities AI automates, documentation, RPM monitoring, structured notes are exactly the things that payers reimburse for. And that alignment is really the bridge to financial stability. And regulatory changes here are not a footnote. They are actually what are creating these new recurring revenue streams. If you're able to capture them over the last 3 to 5 years, there's been a ton of new changes in terms of additional reimbursement codes that pay for services like this. And it's only getting better. I'll talk about some things that they've deployed in 2025 that actually pay for strictly AI-driven care models that don't even require necessarily a clinician to manage. And these policy changes really matter because that is what's going to create the sustainable revenue for this proactive care. Obviously, providing better care for patients is amazing. Everybody wants to do it, but if it's not funded, you're not going to be able to do it. So what we're going to talk about is how that care actually gets funded. And these new care management programs that did expand into 2025 are opening new opportunities for more patients to receive billable care management programs than they really ever have before. There's new codes for advanced primary care, APCM. Those codes completely eliminate the time-based billing and now reimburse based on just delivery and outcomes. So again, those are CPT codes that don't necessarily even need a clinician to deliver. They have to be available, but they don't have to spend 20, 40, 60 minutes of time. And that's available for every single patient. Medicare has said they expect every single patient in your panel to be in an APCM program. This really opens an entire new world for care management, allowing tools like Marcus and Wellbe to become a front line of care delivery, with those clinicians obviously being available in the back end. There are principal illness navigation and community health integration codes that are pretty new service lines that can work in conjunction with things like APCM as really care navigation that gets patients the services they need without overburdening your clinical teams. And the point here is that they reflect Medicare's shift towards supporting navigation, complex care, community resources, and access to these services. They're really designed for you to create monthly reimbursement opportunities for structured navigation and community connections. So as you all are struggling with reduced payments for primary care, lower than average increases in terms of fee schedule that are below cost of living increases, Medicare is expecting you to deliver these kinds of programs in conjunction with that to offset those costs. So these are really not a nice to have add-on. These kinds of programs are really going to be a requirement for primary care to deliver sustainable care in the future. And really, the upshot's pretty clear. Payers are paying for coordinated, proactive care that really prevents downstream costs. And the only catch really is that capturing this reimbursement requires disciplined documentation and really consistent workflow, which is where the automation we were talking about and the nurse capabilities becomes essential. If you're not operationalizing the capture of all this data, the reimbursement disappears. So there's an opportunity to generate revenue while providing substantial care to your patients, but it's just a matter of getting it documented properly and making sure that the codes are billed correctly at the right level of licensure. Along with these codes, there are changes for technology solutions like RPM and RTM that have been around for a little bit, and also behavioral health and collaborative care. They become additive for a lot of your patients. And also, if you think about those, it's a lot of data to feed these AI models that you're capturing on your patients. And again, these technology and behavioral health solutions are really not optional add-ons. They're really central to whole person care. Services like RPM and RTM and I would say they've been sort of novel concepts over the past few years when deployed individually. They're interesting data points, but they're becoming increasingly required as a component of this whole person care of how you're capturing everything going on with this patient at home. As things evolve in terms of data collection, devices patients are using, wearables, this is only going to expand in terms of the level of information that you got. And again, using tools like AI to digest that data and just provide actionable information to either an outsourced care team or even your clinicians is going to be important because you're going to start getting overloaded with more and more data. And whilst those programs, are not going to drive significant value as a standalone, when they get deployed as part of a broader care plan, and when you're able to plug this data back into AI models, the results really become exponential and a core component of the business. And from a clinical perspective, this device data allows earlier interventions and adherence checks that we really didn't have before you had this type of wearable data on your patients. And then from a business perspective, which I'm sure is super important for everybody here, getting this consistent monthly revenue for each patient enrolled can stabilize cash flow, and this funds sustained population health programs. Again, the efforts fail if patient onboarding, device logistics, documentation are not operationalized. So you need a program that does this pretty consistently. A technology platform plus the disciplined nursing workflows is the operational glue that turns this data from devices and behavioral health services into this repeatable revenue model. So we've talked about some of the fee-for-service codes. Some of you are in value-based care models, and that's obviously where things are going. How does this work in the construct of shared savings and outcome-driven payment? So we all know that most practices live in two worlds at the same time. There's fee-for-service today and value-based care tomorrow. Neither one of them is a standalone solution. You have to have a model that works in both. And as much hype as there always seems to be around, the transition to value-based care, the truth is that the bulk of your business is still paid at fee-for-service, and it probably will be for a while. And those payments are the predictable revenue you need to build the population health programs. And I think that's where we've always struggled in the move over to value-based care is there's no way you can invest a lot of money into value-based care when it represents 10 or 15% of your total volume. And if 85 to 90% of your volume is fee-for-service, there's no reason to invest in prevention. And that's why these programs are really being pushed by Medicare, because it gives you an incentive to deploy them in a fee-for-service construct and prepares you for more value-based care. So it's delivering in both. We all know that we're moving towards pay for outcomes. Payers want fewer hospitalizations, better chronic disease management, lower total cost of care. And that is value-based care. That's where the margins shift from volume to outcomes, but how do we get there? I would say the strategic insight we see is that you have to have programs that really work in both constructs. Under fee-for-service, codes like chronic care management and remote monitoring behavioral health can create this recurring monthly revenue. And it's not charity. We see it as working capital. Use this predictable fee-for-service cash flow to stand up the enrollment, the logistics, the devices, the staffing, and all the integration work that actually makes care management function. and do it now where the dollars are available. They're only expanding right now. So this is the perfect time, if you haven't already done this, to deploy some of these programs in a way that's going to drive that revenue and build the infrastructure that you need that maybe can't fund today. And then also capture those codes reliably. Make sure you're tracking your minutes, the consent gets recorded, the notes are structured, because they fund everything that follows. Our point of this deck is revenue now, readiness for tomorrow. So take advantage of that. At the same time, fee-for-service only thinking is pretty dangerous. A program built just to build codes without improving outcomes or lowering the total cost will not survive long-term. Payers are going to move away from paying for volume if the outcomes don't improve. That's why you can't build a program whose only goal is just fee capture. And that's not how we think about it at Wellbe. It's a tool to an endpoint. On the flip side, pure VBC only strategies face a really different problem. Without the near-term predictable revenue, you're not going to have the runway to staff this, implement it, and iterate that model. So VBC alone often lacks really near-term financial ROI to be sustainable, particularly while you're still proving that causal link between intervention and outcomes. That's really where AI matters in a pretty practical way. Tools like Wellbe and Marcus really dramatically reduce the cost of delivery by automating a lot of this triage, monitoring, documentation, outreach, tasking. The marginal cost per patient is going to consistently drop. So that lower cost base means the same value-based care payment produces more margin for you, and it lets you tailor the programs, allowing you to invest actual clinician time where clinical judgment is needed, and then automate the rest where it's not. This combination really widens the gap between program cost and total cost of care. CMS ran their own analysis showing that nearly 75% per member per month cost reduction from patients in care management programs. And as technology drives delivery costs lower, that PMPM advantage is only going to grow. So while fee-for-service creates the funding, AI is designed to reduce the cost. Value-based care is there to reward the outcome. That's how we think about it. Practically operate like this. Start with the predictable fee-for-service revenue, fund pilots, build enrollment, build the documentation, instrument everything, figure out your enrollment rates, your RPM adherence, minutes logged, BP control, A1C control, readmission avoidance, PMPM cost reductions, get all that data, use AI to lower the marginal delivery cost and to differentiate which patients need human touch versus which ones need automated management, both of which can get reimbursed. And then, report those outcomes to payers and translate that into meaningful savings that can help you with your contracts with the payers, or help you get a bigger portion of the VBC shared savings. Just final point, operational discipline matters. Capture and audit all your documentation so that stacking all these codes is defensible. Run a tight PDSA plan and cycles to improve enrollment and outcomes. Program that can live in fee-for-service and scale into VBC is one that will survive and thrive. If you want to succeed in VBC, then don't choose one world or the other. Build a program that earns fee-for-service today, powered by AI, becoming a low-cost, high-impact engine for VBC tomorrow. So if I've convinced you that leveraging this type of AI-driven care management model is the right fit for your clinicians and your patients, then the only real question is whether you're going to build it internally or outsource some of that work. And I can show you how to think about that in the construct of your practice and how we think about it with our customers. So most organizations default to one instinct, just build it yourself. It's cheaper, you own the code, you keep the margins. On paper, it looks much cheaper. The reality behind that instinct is that for almost every practice here, build is actually a costly illusion. To do this right, you actually need clinical design, engineering, product management, integration, security, compliance, billing ops, device logistics, ongoing model training, all operating together efficiently. If you do not already run a technology shop for your practice, you're not going to have capacity to do that day 1, day 30, day 90, probably not even year 1. What typically happens, what we've seen with customers that do move into Wellbe, you build something, it hits a few short-term goals, you've got a prototype that looks okay for 6 or 12 months, Then at 12 or 24 months, you're looking back, evaluating whether it's working, why it hasn't scaled, who's going to keep supporting it, and how has this become a core part of the business. That's really because, quick implemented internal builds really lack operational maturity, the clinical playbooks and iterative improvements necessary for sustained outcomes, and it can be an expensive rerun. I will be clear, building can make sense. We've definitely talked to customers who built this stuff internally and it works. Um, if your strategic goal is to become a technology company that sells to others or really builds this as a core part of your practice. If your main objective over the next 3 to 5 years is just delivering excellent care, running a great practice, building your own care management platforms, really likely the wrong use of capital and leadership attention. I can tell you from our view, this is all we do. It's expensive and it's hard to get right. So it can be costly and distracting for a practice to try to build something correctly in this kind of model. The alternative is obviously buying, but buy smart. Buying doesn't mean handing over all clinical control. It's really finding a partner with a organization that brings solutions you don't have necessarily, engineering, compliance, payer experience, clinical operations, and you don't have time to reinvent the wheel. Obviously, we would love, for Wellbe to be your partner, but we're not a fit for every practice. What I can share after doing this for the last 5 years is a pretty concise evaluation checklist for a partner and whether they're worth your money. One thing I would say is they need to be a clinical first model. Do they have clinicians and real nursing and NP workflows and not just a dashboard? Do you want to pay for your team to look at someone else's dashboard, knowing you probably don't have manpower to act on everything? The clinical team you're purchasing through a partner should own the escalation and coaching. You also need to look at outcomes and operational metrics. We always talk to our customers about clinical, financial, and operational. Those are the things that need to work. This needs to be clinically better for your patients. You're getting outcomes. Operationally, this has to reduce some lift on your part so you're not doing the work. And then financially, is this generating revenue or at least covering costs for the practice so that you're not losing money on that? Those are really the three legs you need to make sure that you're achieving through any partner. Look for measured impact. Are they saving time? Are they reducing alerts for providers? Are they getting clinical outcomes? Are they capturing revenue? You should see real numbers from your customers, not just promises. And this information that I'm sharing shows that, what kinds of outcomes are actually achievable from a financial and operational perspective. Obviously, you want them integrated into the EMR. That's a no-brainer. If you're an Athena customer, obviously Athena has to remain the single source of truth. The good news is Athena is a great partner. They have a lot of open API connectivity. So setting up bi-directional synchronization with data, getting information to your providers' inboxes, getting claims that are billing ready are just really non-negotiable because Athena is such a great partner. Anyone you're working with externally should be able to integrate so you don't have to change your workflow. Make sure that they have billing and compliance competence. You have to make sure that they're audit ready, notes are ready, you've got defensible claims, you've got BAAs in place, you've got robust quality, because the last thing you want is to partner with a vendor, work with them for 6 months, and then all of a sudden have to go back in and audit everything they've ever done. That's definitely important. Also, in terms of AI giving you transparency to the model, how are they training it? How are the RNs providing feedback? How do they prevent drift? That's really important. A lot of new solutions with AI are just going to come as a black box that you're just not going to be able to see. And as you release some clinical decision making into an AI, that's definitely important. Also, economics and shared risk. Like, you should look for partners who are willing to put money or guarantees against performance during pilots. For Wellbe, we've done this long enough. We know exactly how the financials are going to work out, and we're willing to put risk on that. If you come to a partner who wants a big upfront investment for implementation or not putting risk on the table, that's because they don't trust that they're going to actually get paid for the services, and you really want a vendor that's going to stand behind the outcomes, and that's pretty standard in the industry to make sure that you get that. And then also scalability and support. Can they scale clinical capacity? Do they handle device logistics? Is there a single operational owner that's going to help you grow? These programs evolve over time, and if you just launch and go live and you don't have like a point of contact there, it's going to end up deteriorating. So you want someone who's actually with you for the long haul. And we know this kind of technology and codes are going to evolve over time. So you want a partner that can evolve with you. Um, just a word about Wellbe. We built Marcus and the tool to be that kind of partner. We have RN-led clinical operations. We've got an Athena marketplace integration, audit-ready claims, and we structure our pilots that share risks with providers. And you should evaluate everyone the same way to make sure that they're actually a good partner. And also just the practical offer, don't, pick build because it feels like you lost control. Pick a partner and a structure and a pilot that limits downside, proves economics quickly. Wellbe has a 90-day pilot that shares risk for all of our customers, measure clinical and, financial KPIs, and then, hand back a scaled plan. So if your goal is not to become a software vendor, stop telling yourself that you'll build it as a default. You really want to find a partner who will do the heavy lifting, own the technical and operational complexity, and help you win long term. At the same time, if this is a core tenet of your vision for the future, then building internally is not impossible. There are ways to do this at scale, and I'm happy to chat with anyone about our journey building this model, but it's definitely not a small side project to really do it right. At the end of the day, it's all about outcomes. Are your providers happier with this? Are they going to stay with you? Are patients getting the access and the care that they need? Are you generating an ROI for the office while saving for payers? Those are all the things you need to think about in these kinds of programs. So, I'll get into some of the outcomes here that you should expect to be evaluating for any program that you deploy. This is our scorecard, how you should evaluate a care management program, whether or not you build or buy. You should judge it across these 4 buckets. What's the financial impact? What is the provider experience? What are the outcomes? And what are the operational efficiencies gained? Starting with financial, ask, is this covering cost? Is it driving new repeatable revenue? Can it generate enough surplus to reinvest in more programs? Is it worth building? What are the hidden costs? Hidden costs are real: engineering, integration, device logistics, hiring, training, compliance, billing operations, ongoing model maintenance. These things add up and are often underestimated. So whether you're building or buying, you need to, look at what the total financial impact is. Upside, CCM, RTM, APCM, those are not token line items. They can actually become material revenue for any practice. Enrolling 500 patients in a complex CCM program can generate $130, $150 per month, $65,000 a month in revenue, almost $1 million a year. Add on, RPM programs at those 500 patients at 40 to 50 bucks a month. That's another $25,000 per month, or another $100,000 per year. It's meaningful. Stack these codes responsibly, and you're not talking small change. You're talking hundreds of thousands to low 7-figure dollars in new capital that can fund technology, fund staffing, fund expansion. And we're going to show you some of the reimbursements you can expect and how stacking really multiplies revenue. CMS analysis and our own pilots also show that care management reduces total cost of care. We've seen nearly $75 per member per month in reduced costs for managed patients, a gap that widens as delivery costs fall with better technology. And that delta is honestly your negotiating leverage in VBC and long-term source of shared savings. Provider experience, with a provider shortfall, keeping clinicians matters more than short-term margins. Ask, does this program reduce after-hours charting? Does it minimize clicks? Does it reduce, does it return meaningful patient time to clinicians? Does it measurably reduce burnout? Does it give clinicians something they can't get by jumping to a competitor? A better workday, better tools. The right program should save, an hour of care per patient per month and resolve a majority of the routine alerts without physician interventions. Outcomes, this is what pays in VBC. It may not be as relevant in the fee-for-service construct in the short term, but you really want to get that value from any partner, whether you build or buy it. Are patients getting better, lowering readmissions, lowering ER visits, A1C control, improving medication adherence, and most importantly, are patients happier? Are they telling their friends about your practice and giving high NPS scores? Outcomes are the proof you want to bring to payers, and better outcomes mean better total cost, better contracts, and long-term sustainability. Operational efficiency, or just the day-to-day ROI, are your administrative teams more productive, getting fewer inbound calls, fewer no-shows, smoother device workflows, and more patient-facing time for your clinicians, which is what they really want. They want to generate the same revenue, but spend more time with their patients and not feel like they're jumping patient to patient without really getting that interpersonal time with them. The ideal program is going to reduce noise, automate documentation, free schedulers and front office staff to be more productive, more appointments kept, fewer gaps, more revenue. These operational improvements compound and they lower the marginal costs and raise capacity. Bottom line, if the programs don't pay for themselves and improve provider daily workload, demonstrate improved outcomes, and materially boost operational throughput, it's just lipstick on a pig. Conversely, when all four buckets are strong, you've got a strategic asset that provides near-term fee-for-service revenue to fund build-out, lower cost of delivery via AI, and a validated path to VBC upside. That's how care management stops becoming a side thing and a core to how your practice competes and survives. So we'll just walk through real quick a model with Marcus and the AI, and then I'll show you a quick demo of how it works in practice. So Marcus is our AI engine, and then also the nurse team that turns those analytics into day-to-day care team. This slide is thesis in action. A sustainable care model really requires two things: world-class technology and a world-class RN care team delivered as a single total package. We invest heavily in technology for a reason. This isn't, we build something because we can. It's intentional engineering that makes value-based care practical inside real practices. The platform has to do more than display data. It's got to triage, synthesize trends from remote monitoring, draft billing grade documentation, create tasks for staff, and propose care plans that nurses can really customize. Those technical pieces are the plumbing that make low-cost, high-quality care delivery really possible at scale. But technology alone is sterile. Providers and patients don't want a dashboard. They want timely, trustworthy clinical relationships, and that is where our RN care team comes in. Building and managing a nursing organization is pretty hard. I'm sure you all know that from hiring your own teams. Hiring, training, retraining, motivating, scaling clinical staff. It's a full-time operational job. If you skimp on that, you really destroy trust with patients and clinicians, and you nullify whatever the tech is trying to accomplish. So having that backbone is super important. We purposely built both of those deliberately. Our nurses come from pop health backgrounds, VBC. They know about CCM, RPM, BHI, how to document. They're trained to triage up and down, handling coaching and adherence at the RN level, but then escalating to APPs or physicians when needed, and then routing lower acuity tasks to LPNs or care coordinators when appropriate. And really that flexibility is critical because you're going to need the right license at the right time to control costs without sacrificing safety or quality. So, there are two bad options: technology only and staffing only. Tech only promises scale, but fails on trust and clinical nuance. Staff only promotes empathy, but it doesn't scale. You end up with high labor costs and pretty inconsistent documentation. The only durable solution is really hybrid, automation handling the routine, nurses handling the nuance, and the system is there to learn and improve through continuous feedback, which is the model we built. Operationally, it looks like a closed loop where Marcus can identify risks, synthesize device trends, draft notes, care plan templates, and create precise tasks. The RNs can then review, customize, and execute, so they close the loop and provide the human touch. RNs also validate AI outputs, feeding corrections back so that the models can get better. And then in deployments like this, the loop reduces noise, so clinicians receive only really critical alerts and frees up time for patients that need the benefit the most. So the question really isn't whether you need tech or people, it's how to get both integrated and managed so the whole is greater than the sum of the parts. And that's what a total package partner delivers. And that's what really practices should demand in using this kind of solution. So I'm speaking to you from the Wellbe lens, but you can take those learnings and understand what the right model is for your practice, for your providers, your patients. You're here to learn about AI care management. We're one solution, but these lessons are pretty universal. So I'm going to skip the demo real quick to make sure I cover all the slides. We can get back to that. I can also send the team a video of how the demo works, but I want to make sure that we cover it because I'm a little over time. So The three things I want to walk away with is, how this plugs into Athena without new software, how AI is uplifting clinical work, and what the care team actually does, and how this changes your provider and patient experience. Data sync with Athena, no new software for you or your providers to learn. For Athena customers, it's intentionally simple. Wellbe is a marketplace partner with a bidirectional sync. Patient data vitals, documentation, billing ready artifacts are flowing into AthenaNet, and our nurse updates show up in the provider's inbox. Athena is the single source of truth, so you don't need to learn a new EHR or flip between systems. You just authorize access, give us the practice ID. We map to your existing data and workflow. So the data you're already collecting becomes data we use. And that means we leverage your current clinical data rather than asking you to adopt some parallel system. What AI uplifts and what the clinical team actually does. Marcus is able to automate triage, analyzing trends, drafting notes, creating tasks, transcribing calls. Those technical capabilities are the upside. So fewer clicks, fewer after hours notes, automated, artifacts, but the technology is really the enabler, not the owner. Our RN care team does the clinical work you expect. So validating AI flags, conducting patient assessments, coaching patients, escalating when needed, and customizing those care plans. They're also training the models, so every correction and decision is sharpening our own AI. In short, the AI handles the repeatable work, and RNs handle the judgment, trust, and safety. And that type of hybrid makes the model scalable, but also clinically reliable. And then just impact on providers and patients, workload access and process. Practically, this reduces clinician workload. We see a substantial time savings in nursing and far fewer routine alerts hitting physicians. That means less after-hours charting, more time for meaningful visits. For patients, it improves access and continuity, ongoing outreach, RPM monitoring, timely coaching, keeps patients engaged, reducing avoidable ED and hospital visits. And then operationally, processes become standardized, consistent documentation, fewer phone tag cycles, billing ready claims that reduce reconciliation headaches. And the net effect is more capacity, better access, and a cleaner, more predictable workflow for your team. In translation into financials, you understand the tech, you understand the human model. You can picture the operational lift, but I'll quantify real quick how this translates into ROI for the practice and what realistic revenue looks like at scale. This slide is simply a messaging consequence. Like there's a broad expansion of reimbursable codes that cover many different service lines, and these codes change everything in terms of payment models. We're no longer talking about a single chronic care code today. The code set covers advanced primary care, chronic care management, complex CCM, remote monitoring, remote therapeutic monitoring, behavioral health integration, and a host of navigation and social determinant activities. You can be paid for coordinating care, addressing SDOH, monitoring meds and vitals at home, and integrating behavioral health month after month, even when patients don't physically come into the office. Two practical things. One, many of these codes are stackable. So if services are distinct, you can bill multiple care management codes in the same month for the same patient. That multiplies predictable monthly revenue and turns care management into a real operating lever. Secondly, these are repeatable revenue streams. They are generated by the ongoing work of care, outreach, monitoring, coaching, not just by visits. So this creates recurring cash flow that funds the pop health infrastructure. And a structural reality to understand is that CMS is shifting E&M expectations. Part of the reason you're seeing adjustments in E&M reimbursement is that CMS is expecting practices to do more of this ongoing care coordination. In effect, the codes are how primary care is getting paid for continuous care and offsetting or even increasing total primary care revenue while reducing the total cost. Practically, what we see with clients is that there is a material net upside. After implementing, our clients typically net in the range of $100 to $150 per member per month by leveraging CCM, RPM, behavioral health programs. And that portion has been growing year over year as capture improves and delivery costs fall with better technology and workflow. So that margin means staffing, devices, expansion into new programs, all things you want to see. And we don't need to walk through each CPT code. Happy to do that as a follow-up, but just take away 3 points. One, the code set is broad. The revenue is repeatable and stackable, and the rules matter. We help practices navigate the requirement, implement defensible documentation, staff to licensing requirements, and operationalize the capture so this theoretical reimbursement becomes real. I will skip this slide because we're a little over and just wrap up so I have time for Q&A. But just thank you to everyone here for listening to me drone on, really spending your afternoon with us. Hopefully it was helpful and eye-opening about some of the opportunities you have with some of these programs. We walked through the problem. You've got rising panels, administrative overload, the need for whole person care, and a practical solution, AI that can automate the routine, and a nurse-led care model that closes the loop, and the operational playbook to make it work inside Athena. You heard why the hybrid model is a durable approach, and you've got concrete sense of how a pilot could work. So we are here for questions, available after this session as well. If you want to follow up directly, we'll send an email to the group here. Happy to set up a call to kind of look at your specific Athena instance and talk about how this would help your practice specifically. We also have a special offer for webinar attendees that we can talk about after this. But just a logistical note too, we know Athena Thrive is next week. We will be there. We're a proud sponsor. We'd love to meet in person. We're actually doing a happy hour on Monday night. If anyone wants to come to Acme Feed and Seed in Nashville, come by. We also have a booth on the exhibitor floor, booth 706, for anyone who wants a hands-on demo or a private convo. We're definitely serious about partnerships. We'll show the tech, we'll staff the care team, and we work as an extension of your practice. So that is it for me. I will close now and open up for Q&A. We've got about 10 minutes, so ask anything, clinical, operational, financial, or how the pilots get put together. And if I can't answer your question, we can definitely follow up after the webinar. So thanks again. If you're at Thrive, definitely find us, and I am ready for questions, Nikki.
All right. We currently don't have any, Seth. Give it a few minutes here and see what rolls in.
If we don't have questions, I can go back and do the mock demo real quick if we've got time.
Got about 7 minutes left, but I think it's worth it if you have the time.
Yep. Okay. Let me see if I can figure this out. Stop sharing. Can you see my screen?
Yep, you're good to go.
Okay, so this is just a view of our platform. So again, this is just something that integrates in with AthenaNet. So this is a standalone platform that our clinicians are using. This view here is the remote monitoring component. So all the data that we're capturing from patients, these individual blood pressure readings, glucose readings, weights, go into our system, and this feeds our AI model. So this is what stratifies those patients. So we're literally getting steps, activity, weights, blood pressures on patients in real time to help identify which patients are at risk. And you don't have to worry about any of this. This is not getting all bombarded into your provider's inbox, but this is coming into our clinicians and getting triaged based on what the priority is. And I'll show you how Marcus works. So this is one of our AI tools that our nurses can use, and I'll show you how it works. It's essentially reading everything on the patient. So their diagnosis, their lab results, their medications, their vital history, and it'll give the nurses context for each patient. So if I asked, what should I talk to test about during our CCM call, it can tell them based on the historical information on this patient. I hope it works. This is our dev environment, but I can tell you based on the historical information on this patient, what is actually most relevant. So if there's trending vital issues, if there's notes from follow-up from the last time they had the appointment with the patient, that'll all populate in here. Don't know why it's so slow. Hopefully it pops up, but this is pulling all the information like from those notes for the patient. And this is also what's constantly like analyzing everything in the background to push those tasks to the nurses. So this is what's telling the nurse when they're looking at it. So reviewing their chronic conditions, this is what actually is happening with the patients. Blood pressures are variable, several readings in the hypertension range. Have they noticed any symptoms? Medication adherence. Are they taking their acetaminophen and ibuprofen? review any changes or recent events. Have they had hospitalizations, social determinants, what's going on there? So instead of a clinician actually trying to review the last 6 months or year of chart information, this is just going to pop it up immediately so they don't have to do any of that work. And on the flip side, if you think about how your providers are probably treating patients today, they don't have any of this context. So they're just walking in, patient says, whatever, I'm having chest pains, I'm having headaches. What you're trying to construct a diagnosis from that with very little information in a 10 or 12-minute office visit. So imagine if you've got a clinical team sitting in the background that has all this context and they're triaging all of this. So if they need to pop something up, hey, this patient is actually high risk, needs to get involved with the patient, it's going to push an appointment over to the provider immediately with context. Here's what's happening. Here's what's happened over the last 30, 60 days with their at-home monitoring. This is what you should focus on when the patient comes in. Or if we're able to resolve it externally, we're just going to handle that, work with the patient. That could be rechecking vitals, making sure they're medication adherent, getting them under control and dealing with it. And that never has to come in for an appointment visit. But at the same time, that's still billable. So if we have this patient on an APCM program or an RPM program or both, or a CCM program, that's all stuff that's going to get billable to the patient. So they're actually getting access to care and reducing the burden on your staff. Or if they do need to come in for an appointment, you don't have to worry about having that done. That'll automatically get handled by Wellbe. And since you're in Athena integration, that can actually push an appointment directly into the provider so they don't even have to deal with it. So that's a quick overview in a couple of minutes. I can show you a couple other pieces on the care plans, for example. So everything we do is powered by Milliman's care guidelines. So those are NCQA accredited care plans. So we do assessments with the patients. So for example, if you're doing a hypertension self-care plan, these are things that our nurses are either going to ask the patients manually, or these are things that can get pushed out to the patient via an app for them to answer. And we're asking all the NCQA, best in class clinical guidelines of what patients need to know. And then based on that, it'll generate a care plan with specific tasks and activities based on, what are the issues? Do they need to get a dietitian referred? Do they not understand their medication and they need further engagement on that? Like, how do we deal with those questions for the patients? And again, that's stuff that you don't even have to deal with as the provider, but we're capturing that information for you. So that could be, again, like pushing a survey into the patient via an app and having them complete it and then powering that back into the AI to identify like what the gaps are. Or that could be the one-on-one engagement with the nurse, with the patient, and like doing that clinical assessment. So there's a lot of information that's out there to be captured to power some of those AI tools. It's just a matter of how you're capturing it. And partnering with somebody like Wellbe that has that infrastructure is where you get a lot of that value, and why I was saying that building it internally may seem simple, but it's actually like pretty complicated to get all that technology built out and capturing the information appropriately. So I think we are at time, Nikki, unless I can go over, I can go into more, but it's 12 Pacific.
Yeah, we are at time. We did get one question in the chat, and I'll just address it really quickly. It was asked if we were recording this. We are recording. You'll get, anybody who registered will get a copy of their recording in their inbox shortly later today. And then we're also posting it out on Success Community so the Athena Health customers can share that with their colleagues if they desire. Otherwise, Seth, I'll let you just wrap here and we should be good.
Yeah, and I'll just share, we'll send out a copy of the materials too to the attendees. And then if you have any questions, we'll share our contact information. Happy to schedule a follow-up to go into a little bit more detail. And I forgot to just answer a couple questions we had in advance about scheduling. That yes, the AI actually, like, scheduling appointments is a very ideal use case for AI, where it can actually be automated for some of that outreach and getting them actually scheduled. So whether it's reminding the patients that they need it, or actually getting it integrated with Athena to get the appointment scheduled, that's definitely a very simple use case for AI. And then in terms of integration for the front desk staff, again, like things like monitoring the phone calls and automating them and all the documentation, or getting that information plugged into the system, is another really great use case for AI. So anything that is a repeatable or even semi-repeatable task that you're doing is something that can be leveraged through AI. We talk about it in the construct of care management programs, so that's where we get involved. But there are definitely a lot of solutions out there that can automate a lot of that work. And happy to, again, just like talk to you all about how we've seen that and how we're thinking about it, and either if we're a good fit or we can point you to another partner. So again, really appreciate everyone's time. Hopefully it was helpful for the attendees, and we'll send out some follow-ups for the group if anyone wants to schedule any follow-up time with us or our team.
All right. Thank you, Seth. Thank you, team, so much. Everybody have a great rest of your day.
Okay. Thanks, Nikki.